Good morning, everyone. My name is Bedangshu. I'm one of the PICU and a transport consultant at Leicester Children's Hospital, as you could see, which is a part of the University Hospitals of Leicester. And today we'll be presenting our experience as both from the pediatric as well as the neonatal intensive care. So I'll be talking about our experience from the pediatric intensive care. And after me, my colleague from the neonatal intensive care, Dr. Deepa Panjwani, will be talking about the experience of these little ones with COVID pneumonitis being treated with Remdesivir as an experience from the neonatal intensive care unit. So just a Yes, so the Children's Hospital, the Leicester Children's Hospital, so it has a large tertiary neonatal intensive care unit, and then a general pediatric intensive care unit where all these all kind of non-cardiac, and sometimes some of the patients were not complex cardiac patients, they come to the general cardiac intensive general pediatric intensive care unit as well. And then we also have a cardiac intensive care unit at the same site, which is the Leicester Royal Infirmary. So going into our experience in kind of like treating neonates and children up to the age of 16 years. From PICU point of view, so during the time of this COVID pandemic, first wave, second wave for us. So this only includes children coming towards the PICU as well as the HDU, high dependency unit, which we look after. So we had about 8 neonates and infants, and we had about 8 children, which are beyond the age of infancy. As you could see from here, so out of these 8 neonates and infants, 3 of them with COVID pneumonitis, they all received Remdesivir and they were all ventilated. Why I'm saying it specifically, I understand the main idea of our paper was to highlight that, like Remdesivir could be used very safely in this particular age group as well, who presents with COVID pneumonitis and falls in the extreme category of disease. Then after these 3 neonates that received Remdesivir, we had we looked after 3 neonates, but these 3 neonates, I just have to mention here that this is from the time of the first wave, where we did not have much learning or much idea about how and this could affect children, although we were seeing a lots of PIMS-TS or MIS-C, which is the post-COVID inflammatory syndrome, but we did not see a lot of children with COVID pneumonitis. However, the 3 neonates and infants we saw in the first wave, they did not need any mechanical ventilatory support, and within 3 or 4 days with high flow support, they became well and sent back home. There was another one who was on high flow. That's again from the second wave actually, and there was another one who needed non-invasive ventilation. That's for a relatively brief period of time, and that, well, again, there was no clear guidance available for like when Remdesivir should be started. So based on that, and all these children, apart from the vented ones, they did not end up receiving Remdesivir. Having said that, these all came from a multidisciplinary team discussion, together with virology, infectious disease, intensive care, not just within the hospital, our children's hospital, but some more infectious disease and virology experts working on this area specifically within UK. Then apart from that, we also saw 8 children, and out of that, 4 children were ventilated and received Remdesivir. 3 were ventilated, but Remdesivir not received. And there was another, well, then again, I mean, I would not like to go in detail into this into this category beyond infancy. There's a lot to say, but I think for the sake of time and relevant to the topic, we should probably just stick to the neonates, because that's the theme of this presentation, who received remdesivir and how did they present. So as though, I mean, all our experiences, mostly from the neonates and infants point of view, receiving remdesivir. So we published those a while ago at the beginning of the year. The references I have put in there, if someone wants to go through that, please welcome. Then I'm just trying to make my presentation as brief as possible so that my colleague can join in, and we leave some time at the end for discussion. So this is a slide that gives an overview of all the 3 neonates. So as you could see, their gestation, they were all born around, like 30 weeks of gestation, 30, 31, and again 31, and again 33 and 33. And the age of presentation, apart from one, that's a neonate 2, the neonate 1 and neonate 3, they both presented around the same age, actually 6 weeks and 5 weeks. But what is striking here is that I think they were not full term at the time of presentation. Actually, the weight, apart from neonate 2, the rest 2 were relatively good sized. And the most important here is that the main symptom, that all of them, they presented with apnea. And as we would do, I think all these children, they went through the same phase. Apnea, and gone on to high flow, then BiPAP, and they all got vented. They all had presented with apnea and gone through the same management strategy as we would do for any other neonates presenting with the same apneic presentation. So we also looked at other co-infections within other respiratory viruses. They were all negative, and they were from nasopharyngeal aspirates as well as bronchoalveolar lavage after they were intubated. And they all were on mechanical ventilation. As you see here, neonate 1 was extubated 3 days after the start of remdesivir and 13 days after admitted into the pediatric intensive care. But as you could see, neonate 2 and 3, those timeframes are quite, like short. So we'll come back to that later. So as most of our learning in treating, well, at this age group with COVID pneumonitis, their, like pathophysiology, understanding of the pathophysiology, how the disease progresses, use of other pharmacological support, mechanical support, use of remdesivir, it is all based on our experience with neonate 1, actually. So that's why the timeframes are quite long. So I have a slide later that I can explain and talk through. And again, as you could see, the steroids, the neonate 1 received hydrocortisone, but the rest of the 2 neonates, they received dexamethasone. There's a reason behind that as well. So again, we can discuss about that later. And the parents were positive for all the 3 neonates, and probably the likely contact. So going into the lab parameters, I'm not gonna take too much time on this, as you could see here. So for all the 3 neonates, the CRP, the lactate dehydrogenase, ferritin, D-dimer, tropi, even the pro-BNP, they were all elevated. Yes, they are not very, very high as we would see in the in the PIMS TS or the post-inflammatory post-COVID inflammatory syndrome, but they were high, and this is what we have seen in patients with COVID in older children as well. They are higher, somewhere, like 2-3 times, or maybe slightly more depending on patient to patient, but not as high as we would see in post-COVID inflammatory syndrome. So this is the hospital course for neonate 1. As I was telling you all, I think most of our learning is from neonate 1. That's why I thought this is probably relevant to discuss neonate 1 and show it to the audience as well. So if you see here, I don't know whether you can see my cursor moving. So this baby was persistently positive for the SARS-CoV-2 RNA PCR until about day 16. It's been persistently positive, if you could see. We did an extended NPA for the rest of the viruses. They were all negative as well at the same time. So they were all treated as we would do for any other neonates with antimicrobials, which is quite a common regimen being used in the UK. As you could see, when did we start remdesivir for this particular patient? Well, on the day 11, actually. And the reason behind that, I'll come to that in a bit. So if you see mechanical ventilation, this child was um, intubated quite shortly after coming into ITU, then improved, and we managed to extubate this child on day 4 as well, and subsequently worsened. And on the same day, few hours later, about 4 to 5 hours later, he got reintubated. The reason was, one was, like, although we thought, like, and he got better from his apnea, because as he was breathing really well with a spontaneous breathing trial, but after we extubated, he failed to do that, and like, his apnea reoccurred after 2 to 3 hours, and it was so profound that we ended up reintubating. Then in the subsequent days, what we saw was his ventilator requirement, it went up slowly, together with the increase in the oxygen, as well as changes in the chest X-ray. And at the same time, he was persistently positive from the SARS-CoV-2 RNA point of view as well. And at that time, we actually looked at the literature and had multiple MDTs almost every day, whether he's a candidate for remdesivir or not as well. So probably at about like day 8, day 7, day 8, we thought about, like, okay, well, I think we need to bring remdesivir in. And then we had multiple MDTs, and then we agreed finally, okay, we're going to start with remdesivir. But then what we realized that, like, there is no clear-cut guidance available for remdesivir use in children less than 12 years of age. So while that was the biggest, that was the next biggest hurdle then. So again, until then, there was only one reported case from UK where remdesivir was used. So we liaised with them, then another multidisciplinary team discussion, and then we agreed on dose that what we are going to use, and subsequently we managed to start this little one on remdesivir. So as you could see, so there is a bit of like from the decision to start from the decision to think about it, and then finally the neonate getting it is about 3 to 4 days. And if you remember my previous slide, so that's why there's a long gap there's a long recovery period for the neonate one, but the rest of the neonate, it's quite short, because we had our understanding. So when the next two children, next two neonates, they came in, so we had done all the research. We then have a protocol in place which was done locally, that if we have to use this in less than 12 years old, what are we going to do? Yes, so it was quite rapid and very fast actually. So going to the next slide. So that's the chest X-ray. That's as you could see, I've written it down like the worst chest X-ray before treatment with remdesivir. I've just put only one chest X-ray here. As you could see, there is bilateral opacification, but prior to the child was extubated on about day 4, there was a completely normal and a clear chest X-ray, as you could see. So again, so we started on remdesivir, and again, what we learned was that I think we need to monitor the efficacy of the treatment. At the same time, we need to monitor the side effects of the drug as well. So the two, so as in literature, as per literature, I think the two common side effects could be derangement in the renal function and derangement in the liver function. As you could see from the slide, so I've just tried to summarize. I know it's a very busy slide. It's a very busy table as well, but as you could see, I have not flagged up any of the numbers in any different colors, which does mean that we have been monitoring, and throughout the monitoring, what we saw was that the renal functions and the liver functions, they all stayed normal. So again, and how we planned monitoring was, okay, pre-remdesivir treatment. So we were doing it, as you know, we in ITU, we like to look at the numbers every morning. So this is just one of those numbers on any of the days before starting the treatment. And we decided, okay, we're going to look at day 1, day 2. Well, we thought about doing it every alternate day, but then while on treatment, but the treatment course, we decided would be for 5 days. So it's very short actually. So that's why we ended up doing, like almost kind of like every day, because we do not know and how is that going to be progressed. So and we ended up actually doing regularly in the first 2 days, a day break, and then again like in the next 2 days. So what we learned is that, yes, they can present with apnea, as we see in any other children, any other neonates or infants with bronchiolitis. But what we need to remember is that while the pandemic is still ongoing, and like this COVID-19 virus can be a cause of this as well. And we should not forget about that. But at the same time, as we would do for every other neonates presenting at this age, we need to be quite open to consider all differentials. I've written some risk factors as well: prematurity, younger age group, low birth weight. They are quite well, they're risk factors for apnea and progression of disease as well. So, and then we also realized, looking at our cohort of children, that the pulmonary disease progression, it matches with the described pathophysiology as in adults. So then again, as I was saying, that like there was no clear-cut guidance for less than 12 years of age for remdesivir use, and we, based on our experience, we developed a local guidance on the use of remdesivir for all pediatric age group less than 12 years, including neonates. And we also agreed as a team that early treatment, remdesivir therapy, is beneficial and should be considered if we come to know that someone has a SARS-CoV-2 infection, and not just and limited to non-respiratory presentation. And when should we start it? That's still a big debate, but I would say, with my experience, within the first week of illness, it gives the best results in terms of disease progression. With this, I think this is what I have put down in the slide. I think we are never going to achieve a multi-center RCT for like looking at remdesivir treatment efficacy and side effect monitoring. Or probably looking at cases and learning from that is probably the way forward. With this, I'm going to hand over this to my colleague Deepa to present her experience from the neonatal intensive care unit.
Hello, everybody. My name is Deepa Panchwani. I'm a consultant neonatologist in Leicester, and I also work with the Neonatal Transport Service. And I'm joining you today to present our experiences in the neonatal intensive care.
We are glad to have you, Ada. Glad to have you, Doctor.
Thank you. So just following on the presentation from Dr. Saikia, we're talking about babies getting younger with COVID infection. And what I wanted to talk about is the two cases we treated with remdesivir. So our first case, or the index case, was a little neonate, a female neonate born at 32 plus 6 weeks gestation. Her mother was diagnosed to have COVID-19 positive just prior to delivering her. As per protocol, mum received a full course of dexamethasone prior to delivery and magnesium sulfate. And this is protocol for any babies delivering early or prematurely. The female infant was born by normal delivery and was commenced on nasal CPAP at 1 hour of age. She did very well to begin with, and then came off the CPAP and was in air. She had a initial swab, which also sorry, thank you. So she had an initial swab, which showed the baby to also be COVID-19 positive shortly after birth, and therefore she was isolated for this. She then developed respiratory deterioration, and this came on day 4 of life, following with, again, what presented with apneas and prolonged desaturations and bradycardias, and she was then commenced on nasal CPAP. At the time, a chest X-ray was performed and she was started on antibiotics. As you can see, I think I don't know if it's clear, this X-ray to you, but although it appears that there are some elements of our neonatal RDS with ground glass pattern and air bronchograms, this is more marked interstitial lung disease as compared to what we would expect for a normal preterm infant. And following this X-ray, she was continued on nasal CPAP. On day 5 of life, however, she developed a further deterioration where she needed intubation and was given surfactant 200 milligrams per kilogram. However, due to non-responsiveness, she was given an additional dose the following day. However, demonstrated continuing increase in oxygen and ventilatory requirement. She also had a septic scream and was started on second-line antibiotics following this. The X-ray following reintubation, again, although it had elements of neonatal RDS, but it was demonstrated quite severe interstitial lung disease or ARDS, which I felt was consistent with what you would see with COVID pneumonitis as well. And we already knew she was COVID positive on her initial swab. So in view of possibility of COVID-19 pneumonitis, she was, and the fact that there was minimal improvement despite conventional therapy of surfactant and optimization of ventilation, decision was taken to commence remdesivir. Other viral panel was excluded, so all virology was done, which showed that she did not have any other viruses contributing to her illness. And she then commenced on a 5-day course of remdesivir. She initially had a worsening course. So following commencing remdesivir, there was a period of stability. And on day 12 of life, she was noted to have escalating respiratory requirement with difficulties in oxygenating. She was also oscillated at that point of time. She was then started on dexamethasone on day 11 and received a 21-day weaning course and demonstrated marked improvement from day 13 onwards and was extubated on day 14. She went home in air. She did not require any oxygen therapy. The reason for the delay in dexamethasone therapy was because her mother during pregnancy had tuberculosis meningitis, and we wanted to exclude tuberculosis in the baby as well. She did not have any negative swabs on checking, and I think we didn't actually repeat a RNA swab because she demonstrated a marked improvement. What you can see, though, however, post intubation, her lungs did not make a marked improvement, and therefore the remdesivir we felt has contributed to her improvement. Moving on to our second case, this mother was also known to be COVID-19 positive. She had 1 dose of dexamethasone and magnesium sulfate prior to delivery. Baby was then born at 30 plus 2 weeks gestation via an emergency cesarean section. She demonstrated evidence of respiratory distress syndrome of newborn very early on and was intubated at 23 minutes of life. She was given surfactant and commenced on antibiotics. Her X-ray similar to the first, although it's not as marked, you can see some evidence of respiratory disease of the newborn with ground glass patterns and air bronchograms. However, this is again slightly more than what you would expect, and therefore we felt that this was likely to be interstitial lung disease consistent with our COVID pneumonitis. However, we tried to manage this conservatively, and we then repeated a chest X-ray on day 7 of life due to challenges with ventilatory support and difficulties in oxygenating. There continued to be marked interstitial lung disease changes with no improvement in baby's condition. And learning from our first case, a possibility of COVID-19 pneumonitis was considered. We ruled out any other viruses and we commenced remdesivir on day 9 of life for a period of 5 days. She had a relatively straightforward course and was extubated on day 12 of life, and she had been off respiratory support since day 13. And she did have a final swab which was negative for COVID-19. Similarly to our PICU colleagues, we did monitoring for side effects. And just bringing your attention to the creatinine, in neonates, although the normal range is 15 to 21, in neonates, we take anything under 60 as normal. And therefore, neither one of these neonates suffered a large So what we learned from this is common things are common, and therefore we treated for neonatal respiratory lung disease as we would for any other neonate. However, when conventional therapy does not appear to work, we have to consider other possibilities. And in our babies, it was the possibility of transplacental transmission of COVID-19. We also note the similar learning objective to our PICU colleagues, which is pulmonary disease progression is atypical of RDS of newborn, and it matches to describe pathophysiology of SARS-CoV. Can you hear me? Hello?
Yes, we could hear you.
Thank you. Sorry. Dr. Saikia is behind me and he says he's disconnected. So I was just checking. So it is similar to pathophysiology described with adult lung disease. Thank you. So I'd like to open to any discussion and questions. I'm here. Do you want to just, oh, what happened?
Any questions from the speakers?
May I have one question? Dr. Krchov from Slovakia.
Yeah.
Perfect. Thank you for your perfect presentation. And I would like to ask you on that period of your cases that you, was the incidence of COVID positivity very high in your region, or it was only the timing of the diseases when it happened? It was last year?
So as I said, because I presented the data only from the intensive care point of view. So we only see children, coming to a high dependency unit or pediatric intensive care. So as you could see, our numbers were 18 or so that came to us, and out of that, only 6 received Remdesivir. That excludes all the children coming to the children's hospital and staying in the children's hospital ward. So I cannot give you those exact numbers are not in front of me, but I do know that during the time of the first pandemic, as well as the second pandemic, the wards had a significant number of children receiving support on the unit as well. Well, at the time of the first wave, so they just probably received just supportive treatment. And I'm aware that some in the second wave, they ended up receiving Remdesivir while in the ward as well. And now as a region, not just Leicester Children's Hospital, the rest of the DGHs and other tertiary care setup is seeing as increasing number of children coming with COVID as well. Yes, of course, their severity is quite varied, some very mild, to some very unwell, needing to come to HDU or ITU.
So after the period of vaccination, do you have, I mean, that you see some changes in the incidence of COVID infections in neonates after the period when more patients are vaccinated, or there is some difference? How do you feel it? Because we know that the incidence of COVID infection in neonates is very, very low. So it is around 3 or 4% maybe. Did you see any changes after the period when the majority of the population is vaccinated during this, for instance, the third pandemic?
So we actually had no cases in the first wave of the pandemic. I think we had positivity later on, but they did not require any treatment, and it was just supportive. However, this was a surprise. This was in the second wave, and we had only the 2 babies that we had. And this is what we suspected was transplacental. We have not had any since. So in terms of your question, I'm not sure if this was sporadic or whether there's an actual wave changed due to the immunization status.
Yeah,
Thank you. Yeah.
I agree, because I think we don't have the data yet, isn't it? We, at least from my point of view, because from my transport experience, so I do not think we have managed to look at that correlation yet.
Yeah, and if you sorry that I have so questions, but we still have a few mothers with COVID positivity, and majority of them have COVID negative babies, and still we does not have in our region any severe complications in neonates. So, and we are quite big center for it. So this is why I'm asking it. And do you have any information about the could you tell me that if the mothers have a little bit more complicated COVID or less complicated, if it was connected, if the mother is more ill, that the risk that the baby have this complication is higher or not? What about these two mothers?
So the first mother was actually very complicated. As I mentioned, she had TB meningitis during her pregnancy and then actually developed COVID when on discharge. So yes, she was complicated. The second mother, not that complicated, relatively straightforward. But the virus, when we typed the virus, the first one was a Delta variant. The second one was a mutant pathology. So whether it was the mutation, that's the problem, I don't know. We have had mothers who've gone to intensive care and delivered babies with COVID positive mothers. The babies have been absolutely fine. A lot of them have been negative actually and not demonstrated any worsening respiratory symptoms. So it's very difficult to ascertain whether it's maternal status or on just two cases. And I think probably we'd have to pool from other centers who have treated and see what their epidemiology is like in the mothers who have delivered when they are COVID positive.
Excellent. Thank you for answers. Thank you.
Thank you, Dr. Bedangshu, and thank you, Dr. Peter.
Thank you.